Dear Chairman, thank you very much for the kind introduction and for the possibility to talk about this important topic about visceral pain and the lessons that we can learn from the specific example of chronic pancreatitis. I will bring in, right at the beginning of my talk, a perspective that of a surgeon, because I myself actually am a surgeon. And this is the CT image of a patient that we did surgery on around 2 months ago. And for those of you who are familiar with these images, you will immediately recognize that when you look at the pancreatic head region, you will see an enlarged pancreatic head and multiple calcifications, which we call pancreatic stones. Now, these patients suffered from severe pain, and the patient was not responsive to medical treatment, so we performed the pancreatic head resection. And this patient was actually quite quickly relieved from the pain that he experienced. Now, every time when we perform surgery in these patients, we feel that the success rate is really not low. So we ask ourselves, why could we help this patient actually? Was it just a mechanical effect, a mechanical reason? That means, was it due to a decompression of the main pancreatic duct? Was it because of the decompression of the neighboring duodenum? Or was it because we simply removed the inflammatory mass in this patient? Now, while such, let's say, mechanical reasons are possible, we should also consider that there may be another reason. There are animal studies that actually beautifully show that when you look at the nerve density in the pancreas and when compare it between the head, body, and tail region of the pancreas, there is a difference. That means that the sensory CGRP positive fibers are mostly located in the pancreatic head. So by removing the pancreatic head in a patient, we can actually be quite certain that we are having an influence on the sensory innervation of the pancreas and possibly also on the pain sensation. So if this is the case, we could ask ourselves, why not perform a radical therapy and we de-differentiate the pancreas by transecting the splenic nerves that carry the sensory fibers. This will be a de-differentiation of the extrinsic innervation of the pancreas. And this has actually been quite frequently done in the past, but I must say not currently, because we know that in 72% of patients with chronic pancreatitis, when we do this kind of de-differentiation, these patients do not experience long-term relief from their pain. And this study actually also looked at what may be a reason for why some patients benefit from it and why some patients do not. And they therefore classified their patients into those who are taking opiates versus those who are not taking any opiates. And they could show that those who were on opiates are the ones who had much less pain relief than the ones who did not take any opiates. So now comes the term of pain memory into the game. So it seems that when we have patients with chronic pancreatitis who are on long-term pain medication, especially on opiates, there has to be some central changes, and these were beautifully shown by the group of Professor Druvis in the past years, terms like central sensitization in chronic pancreatitis, but as I will show to you here, also altered brain microstructure and neurodegeneration. That means that chronic pancreatitis is associated with a concomitant central neurodegeneration have been introduced into the medical literature. So we can say that chronic pancreatitis actually changes the structure and function of the brain in case of a chronic pain syndrome. Yet, we should not forget that every central change that is induced by chronic pain is based on an interplay between the periphery and the central nervous system. We know that there are central changes happening in the brain, in the spinal cord, but we know that there are also some peripheral prominent changes that occur at the level of dorsal root ganglia. We know this from experimental models mostly, but from human studies we know that there are also several changes that occur within the pancreas itself, both in the intrinsic and the extrinsic nerves of the pancreas. And I will try to show to you some reasons why study of especially the peripheral changes may also provide us with some novel therapeutic opportunities. If you look at the nerve morphology in the pancreas, here is a typical example of nerve morphology of a normal human pancreas, stained with a pan-neural marker, in this case PGP9.5. You see these small nerves, immunostained brown here, located in the interlobular septae. And when you compare this morphology to, for example, nerves in the chronic pancreatitis, you can immediately see a prominent increase in the size of the nerves, but also in the density of the nerves. And many of these nerves are surrounded by inflammatory cells, a process that we call neuritis. And a very comparable disease in terms of nerve alteration is actually also pancreatic cancer. Also in this disease, we see very prominently enlarged nerves, and a big portion of these nerves are at the same time infiltrated by pancreatic cancer cells. And we know that this neural invasion is also a factor that promotes neuropathic pain. But in any case, we can say that the neural hypertrophy and increased nerve density are two characteristic features of the innervation in chronic pancreatitis, but also in pancreatic cancer. So these three terms, neural hypertrophy, neural sprouting, and the pancreatic neuritis that I showed to you before, are known to be directly correlated to neuropathic pancreatic pain. I'm talking about the correlation, not the causation, but the correlation of all these three factors to neuropathic pancreatic pain led us in the past years to study some reasons, or let's say some mechanisms, that may explain the link between these two phenomena. So which treatment options can actually be derived from the peripheral changes in the pancreatic innervation that occur in chronic pancreatitis? If we talk from a neuroscientific perspective, if we have a normal nerve in front of us, and if we remember what happens in chronic pancreatitis, we can say that, first of all, one thing that happens is a neuroplasticity, because nerves get more and nerves are increased in number. And what else happens? What happens is a neuritis, as I told you, and actually is neuroscientifically what we have is a neuroinflammation. And these two phenomena are potential therapeutic targets. And our recent efforts in the past 5 years were actually targeted toward addressing these two issues in different mouse models, but also in vitro models of pancreatic diseases. So to start with neuroplasticity, a simple way to simulate neuroplasticity under in vitro conditions is actually this model. In this model, we collect dorsal root ganglia, spinal cord dorsal root ganglia from the lumbar regions that innervate the pancreas, and we digest these, but we can also do the same assay with myotic plexus neurons, and we treat these neurons with tissue extracts derived from our patients. The patients who undergo resection, let's say for chronic pancreatitis, can also be pancreatic cancer patients. And we fix these cultures under a treatment period of 48 hours, and then we quantify by means of neuronal markers, but also glial markers, the density of neurons and glia cells in these cultures. So what happens when we treat these cultures with human tissue extracts? On the left side, you see normal pancreatic tissue. This is real human normal pancreas derived from organ donors whose pancreas could not be allocated to recipients. So we have a really perfect control in this case. And if you look at the neurite density in this culture, and when you compare it to chronic pancreatitis treated neurons, or pancreatic cancer tissue treated neurons, you can easily recognize a difference in the density, but also in the survival rate of the neurons. And you can use this assay to block or deplete several factors from these human tissue extracts. In this case, we started with NGF. We knew that NGF is highly upregulated in chronic pancreatitis, but also pancreatic cancer. And by using blocking antibodies, one can actually reverse these changes and suppress the density of these cultures. So possibly NGF could be a mediator of neuroplastic alterations in the pancreatic microenvironment, these data, of course, being in vitro at this stage. But we should not forget that NGF itself is a direct nociceptive sensitizer, because by binding to its receptors, be it TRK or P75, it can actually drive the expression of several pain-related receptors. For most of these are familiar to you, like TRPV1, but also several ion channels. And this really happens by direct driving or direct augmentation of the transcription also of some neuropeptides like substance P, but also some neurotrophic factors like BDNF, but also its own receptors. So there's also an autocrine effect that is happening here. So NGF, therefore, by no surprise, was in very early times considered as an analgesic. And there are actually several companies that have developed anti-NGF antibodies for clinical trials. Here is a selection of these, but some really leading pharmaceutical companies have started trials with these agents in different stages. These are the latest stages that were reported, but some of them actually were suspended due to some reported side effects that patients reported while taking these anti-NGF antibodies. And the first one of these antibodies that was developed is Tanezumab. Tanezumab was developed by Pfizer back then, and actually one of the first trials that Pfizer started when studying anti-NGF was with chronic pancreatitis patients. This study, as you can see, was started more than 6 or 7 years ago. But all these trials, including chronic pancreatitis trials, but let's say trials related to low back pain, osteoarthritis of the hip, but diabetic peripheral neuropathy, had to be terminated due to some reported side effects that patients experienced. Yet, the situation changed very recently after the pharmaceutical companies could convince the FDA listed here, these companies could convince the FDA that the anti-NGF therapy does not induce that many side effects. So this is why two companies are already preparing to resume a phase 3 trial to retest anti-NGF therapy in a chronic pain condition. So we can expect that also in chronic pancreatitis, such trials may again follow. I will give you another example, this time related to neuroinflammation. Fractalkine, most of you may be familiar with that, is a neuronal chemokine, and it binds quite selectively to its receptor CX3CR1. We previously studied the expression of fractalkine and its receptor CX3CR1 in human chronic pancreatitis samples, and we looked at nerves that were affected by inflammatory cells, that means that had a neuritis around themselves, and compared to those that did not have a neuritis. And we could actually quite easily see a difference in the expression of fractalkine on the left side and of its receptor CXCR1 on the right side in nerves that were inflamed. So this was quite an interesting target to us. We further looked at its expression at mRNA level, and we classified the patients depending on their pain degree, starting from 0 to increasing degrees of 2. And we saw that also at the mRNA level, especially the fractalkine mRNA, but also the protein level, there was an upregulation of this chemokine in patients who had more severe pain. So we therefore used a quite well-established model to assess mechanical abdominal sensitivity by inducing both acute and chronic pancreatitis in mice by repeated injections of cerulane, which is a secretagogue that I would say induces a rather mild form of both acute and chronic pancreatitis. And we used from Frey filaments to assess the sensitivity. And you can actually beautifully see that when you compare, for example, wild-type mice to those that have a knockout for the CXCR1 receptor, that these mice that are knocked out for these receptors develop much less pain over the course of the pancreatitis, which it reaches its highest extent around the time of 8 weeks. So knockout situation produces this effect. So what would happen if you administer an inhibitor of CXCR1 to these mice? And this is what we did in the next step. So we treated these animals with a specific CX3CR1 inhibitor, and at the 4-week we could already see that the animals that were treated by this AZ inhibitor experienced less pain than those that did not receive an inhibitor therapy. And when you come to the end of the experiment, let's say at 8 weeks, the pain level of these animals that were treated with CXCR1 inhibitor was about the level of the control animals that did not have any pancreatitis. So it was such that by treating the animals with these inhibitors, we could induce a painless pancreatitis, you can say. So for understanding pancreatic neuritis, one essential step in our studies was to understand which inflammatory cells are actually present in this huge accumulation of immune cells. And do these immune cells actually, or let's say the subpopulations of these immune cells, correlate to the pain severity of the patients? For this purpose, it was necessary to perform a systematic immunohistochemical analysis, which we did, where we analyzed the neuritis in chronic pancreatitis patients, and we only looked at the nerves that were infiltrated by inflammatory cells. And as you will see, we used several markers for different subsets of inflammatory cells: panleukocyte marker, B lymphocytes, T helper cells, macrophages, plasma cells, eosinophils, mast cells stained here with tryptase, but also the cytotoxic T cells stained with CD8. And we saw that these populations were actually composed of only 3 types of cells. And these cells were CD8 positive, CD68 positive macrophages, CD8 positive cytotoxic T cells, and tryptase positive mast cells. So to compare the situation to another disease where we know there is again neuritis, we next analyzed pancreatic cancer. So we performed the same type of staining, this time in pancreatic cancer tissues. And what we have seen there is that we again have only 3 populations that compose these neuritis lesions. So again, these are the CD68 positive cells, the CD8 positive cytotoxic T cells, and the tryptase positive mast cells. But when we then classified the patients into those who have pain and then compared them to the, let's say, relatively low number of patients who did not have any pain, and compared the amounts of these populations, we have actually seen that there is only 1 cell population that is enriched among those patients who had pain. And these were actually tryptase expressing mast cells. So although we have 2 different diseases, we see a very comparable phenomenon. That means the specific enrichment of mast cells, tryptase expressing mast cells, around the nerves of patients who have pain versus those who do not have pain. So although these three populations are involved in this process, we can say that only the mast cells may be related to the pain sensation. So why not inhibit mast cells, or why not apply, let's say, stabilizers of mast cells and check what happens with pain sensation in chronic pancreatitis? You know that some of these substances are routinely used in clinic, like chromoglycate or ketotifen, or we can also use some more, let's say, specific antagonists that may target mast cells as well. So in the next step, we used our chronic pancreatitis model, again the sterolane-induced model, and we applied two different mast cell stabilizers, one chromoglycate and the ketotifen. And in both cases, we could indeed see that when compared to the control animals, which had pancreatitis but did not have an analgesic therapy, the abdominal mechanosensitivity of the mice could be reduced by application of only chromoglycate or only ketotifen. So this was not an add-on analgesic therapy. These substances were given as a sole therapy to these animals. So the mast cell stabilizers were able to reduce the abdominal hypersensitivity in these mice with chronic pancreatitis. And you can see the corresponding poster also in the poster session, poster P14 tomorrow, presented by my colleague Dr. Klaus. Another, I think, example that I want to give you is related to the autonomic innervation, and especially to the nerve fibers that are present in these enlarged nerves. So you will of course know that there are mostly sympathetic but also parasympathetic nerve fibers that are present in the pancreas. And we also analyze whether the distribution of these fibers actually changes when we look at chronic pancreatitis, and especially at nerves that have a specific neuroinflammation around them. And also this graph, if you look at the color codes of these nerves, suggests to you that there is a change, because we know that especially in nerves in chronic pancreatitis, we see fewer sympathetic nerve fibers, and these red sympathetic nerve fibers are even less when we have nerves that are infiltrated by inflammatory cells. So we actually have a loss of sympathetic nerve fibers in human chronic pancreatitis samples. And throughout my talk, I gave you examples as a comparison for pancreatic cancer. What do we see there? Tyrosine hydroxylase staining to label sympathetic nerve fibers, and choline acetyltransferase was used to label parasympathetic nerve fibers, and you can immediately see that in pancreatic cancer nerves, we can hardly detect any tyrosine hydroxylase nerve fibers. And this effect was also prominent around nerves that were at the same time infiltrated by cancer cells. So similar to chronic pancreatitis, also in pancreatic cancer, we have a loss of sympathetic fibers as well. But why is this information relevant for pain sensation? If we have a loss of sympathetic nerve fibers, we can say that the nerve interior, the nerve quality, fiber qualities are changed. So we term this neural remodeling. So the basic question is, when we lose sympathetic nerve fibers, we should not forget that we have enlarged nerves. So are maybe sensory or nociceptive nerve fibers simply replacing these sympathetic nerve fibers? And is this the reason why patients maybe have more pain? To study this, we should consider that it may be the dorsal root ganglia that alter their chemical code, and they alter, let's say, their sprouting pattern. That means sprouting more into the pancreas and thereby producing more nociceptive fibers within the pancreatic nerves. So do nociceptive fibers actually sprout off the pancreas, innervating dorsal root ganglia? We, for this purpose, first of all, asked ourselves, could our hypothesis be correct? That means, let's say, markers of nociceptive fibers, very classical ones like substance P or CGRP, are they actually more prevalent in the nerves of chronic pancreatitis patients? Here you again see an immunohistochemical study where we classified patients into those having no pain, rather a rare population, as I said, and then patients having moderate pain and patients having severe pain. And if you look at the presence, the immunohistochemical presence of substance P or CGRP in these different classes, we actually did not see any difference, to our surprise. But there was one mediator that was really in a pain-dependent manner altered, and it was neuronal nitric oxide synthase. So if this is correct, we thought that we may be able to reproduce this also under in vitro conditions. So we, as I showed to you before, can quantify the density of nerve fibers in these neuronal cultures, but we can also selectively count the nerve fibers that contain, let's say, these neuropeptides. So we have here a neuronal culture stained against beta-tubulin as a pan-neuronal marker, and here we can also, for example, perform a co-staining with here CGRP. I doubt you can see it in the projector, but maybe you can recognize some of these vesicles here that contain the neuropeptide CGRP, and if you overlay these images, we can actually compare the density of nerve fibers that have these vesicles in themselves versus those that do not have it in themselves. So we can selectively actually quantify the density of a certain neuropeptide class. So we did this in our culture system. We treated the dorsal root ganglia with normal pancreatic tissue extracts and looked at the density of nNOS containing nerve fibers. And when we compared this to chronic pancreatitis patient tissue extract, I hope despite the projection you can recognize that we have indeed seen a prominent increase in the density of nNOS containing nerve fibers in neurons that were treated with human chronic pancreatitis tissue extract. So rendering another target for us to target pain in these patients. So we went ahead, this is a very new result that we produced a couple of weeks ago, to analyze what would happen if you provide, or let's say administer an inhibitor of nNOS to these animals. And we used a very selective nNOS inhibitor, the NPLA, that we supplied to these animals by injection on the one hand and simultaneously via drinking water. And also under this therapy, we did see lower mechanical abdominal sensitivity in the animals, in the mice with chronic pancreatitis when compared to the control animals. So, if I may summarize, in this talk I tried to explain to you why I think that studying peripheral changes in chronic pancreatitis and maybe also in other diseases may provide us with important targets for novel analgesic therapies. And two reasons to target these are that, first of all, there's a neuroinflammation going on, and also there's a prominent neuroplasticity. And understanding these molecular, the molecular mediators of these two phenomena, let's say NGF, CX3CR1, and nNOS, but also some cellular mediators like mast cells, can, in my opinion, provide us with novel analgesic targets. But beyond these primary neurons, it may be also interesting to study second-order neurons, also in the spinal cord, that may be influential in this process. And for this purpose, I think animal models can also be very helpful. I thank you very much for your attention.